during this lecture. I'm an FY1 at Jimmy's doing colorectal at the moment. And today I'm going to talk to you about last year's exams. I've shamelessly stolen pretty much the entire PowerPoint from the one we had last year, but not just because it was a snappy title, but also because I thought it was really reassuring. I think that's important at this stage, and hopefully I'll be able to do the same for you guys today. So, aims and objectives. Mostly I'm going to run through the OSCE, what we got last year, and then do a little bit about the written papers and the slide exams, but I didn't want to spend too much time because apparently you guys have had quite a bit on that already. Then do some general exam tips, and then hopefully that will be done quite quickly so that if you have any questions, hopefully I can answer them for you. But just to give you a bit of a context as well about myself, as I said, I was a Leeds graduate, but I wasn't particularly hardworking or a very good student, and I still managed to get through the exams, so hopefully that will reassure you a bit. And also, I thought that the OSCE, it was really clear most of the time what they wanted from you, and some of them were really simple, and you thought that, well, I thought maybe that I was missing something, but they really were that simple. They threw a couple of curveballs at us, but if you could give them a good shot and reckon that you ticked enough of their random worksheet to pass. So, right, so the setup for the day, we had 14 stations. On the first day, you had 12-minute stations with one rest station. They were mostly history-taking, explaining, reasoning. Then we had 7 on day 2, no rest station. There were 8-minute stations, and that was mostly focusing on examinations and clinical skills. And that's what it was like for the year previous, in that they grouped them together. So probably will be the same for you guys this year. All right, so we'll start with day 1 of the 12-minute stations. So my first station was bar and door, renal, colic, history, loin to groin, pain. I took the history, I presented to the examiner. I was so nervous. I said it was close this service. And she was like, really, do you want to talk through the exam again, or the history with me again? And then it sort of dawned on me. And so they help you along. And I was shown the USNEs, and then you talked about which, surprise, shows AKI. That's one thing I can probably guarantee will come up in the OSCE, is AKI. And then you just talked about the management of renal colic as well. So really manageable station. The second station, I didn't really know what to call it because it was one of the weird ones, so I called it social history. But basically, you had to read a blurb about a patient who was medically fit to go home, but the relative had expressed concerns because she didn't think that they would cope, and the main carer also had to take care of her son with Down syndrome or something like that. And so it was tricky to know the mark scheme, but likely from speaking to a number of people and from what I did, it was determining if it really was safe for the patient to go home and doing a holistic care thing and making sure that they got assessed by physios and OTs and just, addressing their ideas, concerns, expectations. So you could give it a really good stab even though you didn't really know exactly what you were supposed to do. This was another really good station. We had breaking bad news and discussing DNA CPR. Again, you were given a blurb. I can't remember if it was a notes entry or just a blurb, but it was clear that the consultant thought that the patient was deteriorating, wasn't going to improve, and just to keep them comfortable. So it was following the 7 steps of breaking bad news as you would, and then so once you established what they knew and broke the bad news, then you sort of started talking about DNAR. And no one that I spoke to had a difficult patient. All of them got upset, but they weren't aggressive or anything. My 4th station was a pneumonia video. Again, this was a great station. You watched a video. They had a productive cough, a fever, shortness of breath. You were shown a chest x-ray, and unlike in 3rd year where you had to do the whole thing, they just said, where is the abnormality? And you pointed to the massive consolidation. And then you were shown an ABG, had to interpret that as well. And then asked about the management of pneumonia. So you went through the curve score, they gave you all the stuff you needed to calculate it. And then they showed you a list of antibiotics with the doses included, and you just had to prescribe on a drug chart what they would be and the fluids. exams, completely forgot what curve stood for, and she passed. So. Then the fifth station was ward round entry. I found this one tough, just because I'm not a very fast writer, but you had to watch a video of, it was supposed to be a ward round on a surgical ward round, and this patient was about to go for surgery, so you have to write the entry. And then after that, they asked you to prescribe the necessary stuff. So it was clear that you had to obviously prescribe the analgesia afterwards, but then I got asked to prescribe pre-op prep, and I had absolutely no idea what the guy meant. In hindsight, it probably was bowel prep, but loads of people prescribed different things from speaking to other people. So it wasn't that clear, but as long as you prescribed something and you were safe, I imagine it was all right. So I absolutely bombed that station, and I'm still here. The next station was a collapse history. This was just, it wasn't very clear why she collapsed, but I don't think that was the point. It was just trying to prove that you could take a good general history and then afterwards discuss what you'd like to do in terms of investigations and management for this person. And that's all they asked you at the end was, what would you do now? So that was fun. And then the last station was a diarrhea history. It was a really anxious patient, recently been investigated for IBD, had a colonoscopy, and it was normal. And then as you took the history, you realized that they had been recently put on antibiotics, and lo and behold, it was cephalosporin. So you paused, or at least for me anyway, they paused the station, and the examiner said, do you think it's likely that, or what do you think is the likely cause for the diarrhea? Do you think it's IBD? And you have to be like, no. And then he's like, do you want to repeat the colonoscopy? Do you think that's, that's what the patient wanted? And you'd say, no, that's not appropriate at the moment. And you would say, what would be appropriate? So doing bloods and a stool sample, sending it off for C. diff toxin, and all the neurology. And then you took a break from that, and my examiner said, okay, now I want you to tell what you've told me to the patient and reassure them. So I hopefully reassured him. And then prescribed the drugs that you would to treat C. diff. That was day one. So far, so good, right? And then day two were the 8-minute stations. So a great station to fill out a death certificate. One of my friends was convinced it was a trick and you weren't supposed to fill it out. So she sat for 8 minutes in silence with her examiner. She's working Nazi. Then the second one was venipuncture for blood transfusion. You have to take a blood sample and demonstrate the proper way to take it to make sure that you're getting it from the right patient, labeling it whilst you're there. And then talk about the indications for transfusion. So I think, I can't remember if you were shown anything for the patient, but talking about if their HB was less than 8, if they're symptomatic, etc. And I know Johnny Greck, who did it last year, they had to do venipuncture, and he said he tried 4 times and couldn't get it. So you don't even have to successfully get it, just show good technique. Then we had cannulation and fluid prescribing. I thought the packs were really weird. They were missing lots of stuff. But the examiner was more than happy to empty stuff onto your sterile field and help you along. And then you were shown an OBS chart for this patient that you cannulated, and they were hypertensive, so you had to prescribe them a fluid challenge and maintenance fluid. So, very, very reasonable station. No tricks. Then we had a respiratory examination. My patient had pulmonary fibrosis. I could hear that it wasn't quite right, but I didn't really know what to say. Then I showed spirometry results, showed a restrictive defect. I was able to say it just as the bell went off, and I got a big smile from the examiner, so I think I passed even though I couldn't hear what it was. And they had the exact same station the year before, so may or may not come up this year. I think it's not so important that you get the diagnosis. Obviously, it's good if you do, but as long as you you know, say that you recognize that it's not right, you get your senior to look it over and you do these tests and you can interpret the tests then. That's fine. Then we had a cardiology examination. No one could agree afterwards if it was aortic stenosis or mitral regurg. And then you're shown an ECG, which was fast AF. So again, I'm sure you guys can do that. I hated this station. We were shown a video of a man with Parkinson's disease, and there was a doctor performing these various tests on him to demonstrate, I guess, the features of Parkinson's disease. And they would stop the video intermittently, and the examiner would ask you questions. It was awful. They showed him walking, and then she stopped the video and asked me what I saw, and I said that he had a shuffling gait. And she said, yes, what else? And I said, okay, he had trouble turning. And she was like, yes, what else? And I couldn't say he was cogwheeling because they weren't demonstrating it at that point. So I was like, he has a fascinating gait. And then she was like, what else? And it was just that. But it was the only bad station, and everyone I spoke to thought it wasn't very good. So if it's just the one, you bear it. It's a long 8 minutes. But and then the last station was drugs prescribing. You were shown a patient's Usenes, and it was AKI. So then you had to transcribe the regular medications on a drug chart, and they just wanted you to do responsible prescribing, so omit their nephrotoxic drugs. And I think they were eye drops, but it was a brand name, and they wanted to make sure that you looked to death in the DNAR and didn't just prescribe blindly, that you knew what you were doing. And then you also didn't know their allergy status, so they wanted you to sign that box in the allergy box that says that you don't know what their allergies are. And that was it. So in summary, it's all stuff that you can do. But that was all on the OSCE, but I'm just going to briefly talk about the written, well, some general statistics and then the written stuff too. So you will recognize some of your examiners. I had a gastro consultant from Bradford that you guys may or may not have had, who terrified me. But he was actually really nice on the day. I think they know you're frightened. They want you to pass. They're really encouraging. They'll prompt you for release stuff. The normal ranges are included in both the written and the OSCE. And we were given a pad in 5th year. We weren't in 4th year, so I was so happy. But then I never used it once. I think it's just more for comfort. Oh, and then I thought I was being funny, but I'm sure you heard about the guy who ate cake in between our written exams that had nuts in it when he had a nut allergy and had to go to A&E.
And do the sequentials because of things that
and then I accidentally high-fived because I had to stay late to do a station because I had to go to the toilet. And then, so everyone had left, and Dr. Budd, Simon Budd, was like, right, I'll come back and fetch you when you finish the station. But I finished early, so the examiner let me leave. And as I was walking out, he was like, oh, you finished early. And in my mind, I was just so elated that I finished. I thought he was, so I was like, and then he just looked at me, and he was like, no. We had 60 MCQs, we had to choose 1 through 5, what you're used to, 75 EMQs, up to 16 options. We had 90 minutes to do that. I can't remember how long we had for the MCQ. And then the slide exam.
75 EMQs, like, including the set?
Yeah. Yes. Yeah. And then the slide exam, as you know, you had 40 questions over 40 minutes, 1 to 3 questions per slide. And it was a composite bar, so if you didn't think you did very well in one of them, we can make up for it in the end. So that's me done really. Yeah, but it was slightly encouraging. So I hope I haven't worried you guys. And yeah, I really think they tailor the exam, the OSCE anyway now, to make you a confident F1. So it's nothing really strange, you know, it's just things that you do every day that I'm sure you've been doing on placement or seeing F1s doing on placement. I'm sure you'll do really well. Do any of you have any questions for me?
Do you know the MCQ and EMQ, do they compensate with the slide paper? Can you...
I think it's a composite of all three, isn't it?
I thought you had to pass them individually.
It used to be, and now you need to pass it out.
Pass them all individually?
Yeah, but they do
They were
sequential.
nice and cool,
Yeah, but they do sequential testing for the slide tests now as well, which they didn't do before. So if you don't make up the marks in the slide test, you can do that again as well. So that's quite good.
So did we decide that you have to pass on individually, or can you make
the written and the slide test. So,
Like,
I thought that was true, but I don't know.